All of the testing that we do really is designed to address unmet patient and provider needs. So as I mentioned, taking new technologies and innovations and adapting them into clinically available solutions, as you mentioned, for precision diagnostics. So I'm mainly talking about comprehensive options such as whole exome sequencing, whole genome sequencing, and chromosomal microarray. So these are comprehensive tests for patients with rare disease. As you recall, patients with rare disease, especially those presenting in the neonatal intensive care unit or at an early age, can have symptoms that are not specific. And these symptoms and signs may develop over time, may overlap with many other different disorders. And so the time for diagnosing these patients can get quite lengthy. And of course, in order to, address the patient's needs, the earliest and quickest diagnosis for medical management and initiation of management and potentially treatment is critical. So getting a diagnosis fast is the most important thing we can do for a patient. And as we know, genetic conditions can present a little bit differently. Even if it's the same condition, it can be slightly different from patient to patient. So that's why having these tests, which are comprehensive, is really important to address the needs of rare disease patients. There are some data in the literature that typically patients with rare diseases see on average about 8 different physicians. 4 of these may be primary care physicians and 4 of these may be subspecialists. And over this period of time, which can last anywhere from 5 to 7 years on average, the amount of resources that are spent in trying to determine what the diagnosis could be is about 19,000 on average in testing alone. And then during this journey, there can be anywhere on average in the literature, anywhere from 2 to 3 different misdiagnoses along the way. So whole genome sequencing is, just as the name implies, looking at the entire genome. And what I mean by that is it interrogates the genome for a variety of different types of genetic variants. So it can look for structural variants, single nucleotide variants, copy number variants, trinucleotide repeats, and mitochondrial disorders, all in a single test. And so it gives us the best chance of providing an accurate diagnosis quickly so that patients can be on the path to treatment or more effective management. This has been a tool that's been available clinically, I would say, for the past 2 to 3 years. Prior to that, our laboratory did offer it on a research basis through the Undiagnosed Diseases Network of the National Institutes of Health. Our laboratory is the sequencing core for this National Institutes of Health project, which is really looking at patients, rare disease patients, our most challenging patients who have been on the diagnostic odyssey and have been evaluated by multiple physicians without having an answer for their underlying genetic condition. And we've been the sequencing core for about 8 years in this program. So we've had experience, a broad experience, both on a research basis and now on a clinical basis. In terms of becoming affordable, again, you have to look at it from the standpoint of, as I mentioned before, the on average $19,000 that a patient has to perhaps the resources that a patient has to use to make a diagnosis before these comprehensive strategies were in place. And so we now know that there are several state Medicaid programs. I believe there are 8 currently that cover whole genome sequencing, especially and in particular in the NICU. So rapid whole genome sequencing. And now there are 15 health plans that cover rapid whole genome sequencing. So I think the field is moving forward and recognizing this in terms of the clinical utility that this particular test can bring to shorten the diagnostic odyssey. And I gave you some examples of whole exome sequencing, but the same can apply for whole genome sequencing, particularly when there are different kinds of variants that may be responsible for a condition, such as the example I gave where there was trisomy 21, which is chromosomal, and then a single gene defect. So those both can be assessed by whole genome sequencing as opposed to having to have two different tests.